Hi, I'm Dr. Gay Carlson, President of the American Academy of Child and Adolescent Psychiatry, with number 32 of my Screenside chats for our AACAP members. My goal with the chats is to share timely clinical practice and other important information from experts on key topics during the COVID-19 pandemic. Reminiscent of President Roosevelt's fireside chats during the Great Depression and World War II, I've wanted the topics to be informative, relevant, and interesting. Today, we're circling back to a subject we've talked about before, and that's suicidal behavior in kids. I'm really pleased to have someone with me today who is not only one of the foremost researchers in the area of suicide prevention, but a longtime friend and collaborator, Dr. Joan Asarnow. Dr. Asarnow is president of Psychiatry and Biobehavioral Sciences at UCLA and a board-certified clinical child and adolescent psychologist. At UCLA, she does many things, but relevant to this, directs the UCLA Youth Stress and Mood Program, a depression and suicide prevention program with clinical, educational, and research components. Dr. Asarnow has received the 2017 Research Award from the American Foundation for Suicide Prevention for her work in developing and evaluating treatment service delivery strategies. And she's particularly, of course, doing this in the area of suicide and self-harm. She's also recently won the 2020 Distinguished Career Award from the Society for Clinical Child and Adolescent Psychology. I have to take my hat off to Dr. Asarnow. She takes on really serious problems. Her programs are aimed at getting troubled kids where they are in emergency rooms and in primary care. And she's developed a couple of programs that are in the National Registry for Evidence-Based Program, a SAMHSA-run network. One is the Safety Program, a family intervention for suicide prevention. And the other is a depression quality improvement initiative, which is an evidence-based treatment for depression. And it's been integrated into primary care. So as in Sutton's Law, Willie Sutton robbed banks because that's where the money is. Joan goes where the troubled kids are. Joan, I hadn't known that you were going to get a huge award at the time we set up this program, but it's relevant to what we're talking about. Why don't you start out talking about what's happened to suicide risks during COVID, and then talk about what we know about optimal interventions for kids.
Okay, well, let me start by saying thank you for this invitation. It's always a pleasure to speak with you, Gay. And it's a special pleasure to be part of the Fireside Chat series. And
Screenside, not Fireside, Screenside.
Screenside.
Oh,
Okay,
I thought it was so clever.
COVID, right? It's a special pleasure to be part of the Screenside Chat series and to get an opportunity to speak with the AACAP membership and other people who might visit the website. So thank you. So you want me to talk about COVID?
Yeah. So start out talking about suicide and COVID, suicidal behavior in COVID, and suicide and COVID for that matter, and in kids.
Well, COVID is certainly affected all of us. I never thought I'd be living through a pandemic, and here we are. And it's been going on a long time, it seems, and shifting with us. So we've begun to learn some things clinically when you talk to clinicians. What you're hearing is that in emergency rooms, in emergency departments, and in clinical services, we're being pretty overwhelmed with kids who are presenting with mental health concerns and suicidal ideation and behavior, unfortunately. Now, luckily, at least at this point, the provisional data indicates that in the total population, we're actually seeing a decline in suicide deaths. And in our younger population, we're seeing a steady level of suicide deaths. So there really doesn't appear at this point, based on the provisional data, to be an increase, even though we're seeing the increase in suicidal ideation and behavior and mental health concerns. However, we're staying steady at a pretty high rate because rates were increasing before the pandemic. And it may be that our kids are particularly vulnerable because they're experiencing social distancing. They're not with their friends the way they normally would. They're online. They're experiencing school closures. They can't go out and get jobs as easily as they might have. So they're having a lot of experiences that they didn't want to have, and they would prefer to have otherwise. So they may be particularly vulnerable. And we're also seeing an increase in overdose deaths, deaths by overdose in both the total population and the younger population. And because kids who experience suicidality are at increased risk for overdose deaths, that's a particular concern in addition. So it could be, and I hope not, that we're going to see a lagged effect of increased suicide deaths with time. And hopefully we can stop that, because that's our job. And my hope is that we can mobilize ourselves as clinicians and health systems and families and communities to function like what I think of as protective seatbelts, and hold our kids safely so that when they experience really unbearable pain, we can keep them safe until a point when they can see their way through and be able to remember that they really want to live, and to move towards actions that lead to them building a life that they want to live. So that's what I hope.
So why don't you summarize what we know about a few interventions that are effective? Talk about what you hope to accomplish in your PCORI grant, which is just funded. And really, if you can, translate it to the members so they have something that they might be able to do in their venues or practices or medical centers or wherever they are.
Well, I think most of us that take care of kids do have kids who come in with suicidal crises. So a lot of the work that we've done has been in emergency rooms where kids who make the most dangerous kinds of suicide attempts and survive tend to end up because they need medical care. So we've done a lot of work in emergency rooms, and we have made progress. Not just me, the field has made progress. And I'm really happy to say that, because it's so terribly important. We don't want our kids to die prematurely because of mental health concerns. So what have we learned? Well, a big problem that we have initially, which is really quite critical, is that after a visit, an emergency visit for suicidality, almost, well, on average, about half of kids nationally never get needed follow-up care for their mental health concerns. So because getting to follow-up care is critical to receiving effective care, and suicidality in most cases isn't a single event, that there is additional problems that relate to the behavior. Although sometimes a kid comes in because of what they perceive as an unresolvable crisis, and that crisis can be resolved fairly rapidly and they look better. Mm-hmm. So the goal is to provide care in the emergency settings that leads kids to get additional care that they need. And our intervention, originally called the Family Intervention for Suicide Prevention, which we've renamed as Safety Acute to emphasize the safety focus of it, as well as other interventions that have been done in emergency settings and been shown to be effective, tend to emphasize two things. First, the crisis session in the emergency room, where you want to do something to increase safety and to stabilize the kid so that they can go on to the next setting. Hopefully it's home, but some children will need more restrictive settings and need inpatient hospitalization for additional observation and care. And the other part of that is follow-up contacts afterwards. And as one of our stakeholders said to us, when I come into the hospital with some medical problem, like a back problem, I go in, I get treatment, and the next day, somebody calls to see how I'm doing. Is the problem better? Do I need anything? But when I bring my child in for a mental health problem, it's radio silence. Nobody calls, nobody checks. And one of the features of the interventions that have been shown to be effective, like ours, the Safety Acute intervention, is that they include both the crisis session in the ED and this follow-up contact to help them get linked to care. And the whole idea there is that in the crisis therapy session, you're both stabilizing them, you're increasing their skills for staying safe, you're helping the families to keep them safe, and you're giving them exposure to a mental health intervention that feels helpful.
Mhm.
So that would reduce stigma, hopefully, and the barriers of not being certain what will happen. So those are the interventions in the emergency level that have shown the greatest promise.
So tell me how that sounds, because I know in our emergency room, they've been doing follow-up calls for years. And, I'm doing a record study right now. So I read that follow-up call. I would have said in 99 out of 100 calls, no contact is made. Do the people get told in the emergency room, I'm going to send you home? This is a serious event, and we care about what happens to you. Well, I don't know. You can role play what you say. Somebody will call you tomorrow and see how you're doing. Expect a call from 631-751-5078, and we'll be checking up on you. I mean, do you get specific like that?
Well, the world has changed, right? Since the initial work that was done.
Uh-huh.
I had to take the phone out of my study here because it rings constantly with someone trying to sell me something.
Correct.
So people do not pick up their phones anymore.
Right.
And I think that this complicates efforts to reach out to people after they leave an emergency visit. So there are many strategies for addressing that. Like you mentioned, you can let them know that you're going to be calling and telling them from where. And also you can use text messaging to help them to know that there's someone that cares and that they can reach you, or to let them know that you're going to be calling them.
Okay, so you say to somebody, if you don't mind, could you give me a number that I can text you at tomorrow to find out how Mary or George are doing?
Right.
Or do you contact Mary and George directly? Do you contact the kid or contact the parent?
Well, that's also a very important question. And ideally, you would do both, because the parent, now remember, you can only do so much in an emergency contact. Right. And for the kids who have mental health problems that are leading to their suicidality, your real goal is to get them to effective treatment, right? So you want to motivate them, and that's one of the goals in most of the interventions that have been done, that have been shown to work in emergency settings. You want to motivate them to get needed care, both the kid and the parent, and help them to get that care. Now, if you can schedule an appointment right out of the emergency room, that's ideal. Right. But in many settings, you can't do that. And people get referrals, and then it's very hard for them to make appointments. And some people have a physician or a psychologist or a social worker that they're routinely seeing, and they're returned back there. So, needs vary, and I think you have to individualize your approach. And maybe I'll segue into our very exciting, newly announced PCORI Award. That's the Patient-Centered Oriented Research Institute. And we're very excited because we're going to be able to address some of the questions that you asked. As I said, there's really two parts to the intervention. There's the crisis intervention, where you're trying to enhance safety planning and give the kids the skills to use safety planning and build hope. So they want to use the safety plan, because if they're hopeless and want to die, no matter how great the safety plan is, they're not going to use it, right? So you want to do that. And we know that that's done in most EDs. And your ED, I think, is unusual if you are calling people regularly. And there's variation across our EDs, because some EDs have the resources to do that and others don't. So in many EDs, they don't get those follow-up contacts. And that's what we learned from our discussions with patients and families. And I should say that a big part of the PCORI grant is that I, as a researcher, did not design this study all by myself or with my researcher colleagues and clinician colleagues. Instead, we brought together multiple stakeholders, including patients and families and health systems and insurers and policymakers and the clinicians that are providing the care in order to identify what people needed to know to improve care. So this trial is a randomized comparative effectiveness trial where what we're asking is it enough to focus on the ED and doing a really strong crisis intervention in the ED with linkage as usual to follow-up contacts as you described in your emergency room and we've heard about in others? Or do you need to have a therapeutic follow-up contact protocol so that patients have access to continuing contact that lets them know that there's a caring health system out there where they can get care and to provide them with additional support in using the therapeutic components that were offered in the emergency room, the safety plan, the feelings of hope, the reasons for living, and for parents to remember that if your child's upset, you want to restrict access to anything that they could use to kill themselves, particularly lethal methods. So that's really what we're testing. Does it make a difference? Do we need to have these additional resources covered by insurance and our health system policies so that we can provide this continuing care? And we're testing a national call center model. So we're going to offer the therapeutic follow-up contacts through a national call line similar to what's provided through the National Suicide Prevention Hotline. So that'll be very exciting. And I should say I'm not doing it alone. I have
that's the whole country. That would be really great, Joan. What does it sound like, though? I mean, one of the things that I've always loved about you is you are just so, when you do CBT, you just have such a great talent for doing those kinds of things. And I just used to sit back in awe of your natural ability with it. And I imagine that's what happens with giving people hope. But for those of us who are not necessarily versed in that, how does that sound? How does it sound to try to give somebody who's really angry and you didn't call and you didn't let me do what I wanted to do, and I don't have any friends anyway, and what's the point in living? How do you give hope to somebody like that?
Aw.
Don't go, aw. So what's plan B?
Well, when it's at its worst, it's probably in the ER, right? When even the kid has just taken an overdose and it hasn't worked and there's tummy hurts and they've done something to make them feel even worse in the emergency room. And so what we tend to do is try to shake it up, change the rhythm. And so we tend to go in and go, whoa, this has been a really hard day for you. I really get it. And you've been waiting here so long and they made you drink that horrible stuff. And I know you feel awful. Is it okay if we talk for a bit? Okay. Well, I'm not going to ask you all those questions that you've already been asked 5 times, but I would like to know, because I don't know you at all. Can you tell me something about yourself that you feel good about? Something you'd like to share? Because I don't know you. I just read in the record that you took these pills, but I don't know you at all. What would you like me to know about you? And really see if you can drag out the kids' perceptions of strengths in themselves and in their environment. What do your friends like about you? Who are your friends? What do mom and dad do that feel okay? Oh, dad does nothing that you like? Okay, well, tell me about mom. Do you guys ever have time? Nothing. How about grandma? How about any aunts, cousins, teachers, coaches? So you want to see if you can drag out these protective forces out of the child that are going to keep them safe. And if you can't, then you probably are leaning towards a hospitalization or some kind of safer setting to make sure that the child will be safe.
If you were to be a betting woman, would you, what are you leaning towards? Are you leaning towards that the extra work won't get you more bang for your buck? Or Are you guessing that, you know, if you can do it? See, can't imagine that more help wouldn't be good. It's a question of whether you can do it. But anyway, are you guessing that the more help is just really where the action is going to have to be?
Well, that's a really good question. And I'll just say here that our prediction is that the combined intervention that adds the therapeutic follow-up context is going to be the most helpful intervention. And that's what we're testing, because you wouldn't want to add it or pay for it if it doesn't work. Right. That being said, one big part of this PCORI grant is to look at differences in the value of these two different interventions across different populations. And we know that we suffer from health disparities, and many minoritized populations, as well as frontier and rural populations, don't have access to evidence-based treatment, and sometimes don't have access to any treatment. So I believe, based on prior research, my own and others, is that we're going to find a stronger effect in our minority populations, as well as in our rural and frontier populations, because these therapeutic follow-up contacts may provide a lifeline for these people and help them to get to care and want to get to care, as well as deliver some effective therapeutic components. They're more than a caring contact or a follow-up call. We really aim to boost the ED intervention through these therapeutic follow-up contacts. And there are data to show that this was effective in a large trial with adults in reducing suicide attempts later.
Aren't you going to be running into the rate limiting step of there's just not enough providers or places or whatever to provide that care? I know our outpatient clinic is inundated with people. Everybody that I've spoken to just doesn't know where the extra help is going to come from in order to not just provide for suicidal kids, but just more kids that are going back to school or aren't going back to school that are going to need extra help. Anyway, the point is we have a workforce issue, and the workforce issue isn't just in child and adolescent psychiatry. It cuts across the entire mental health field. So how are you going to make room in order to be able to test your hypothesis that when somebody provides continuity, that there is somebody there to provide it?
Well, hopefully in our study, we'll have the funding to be able to do it. I don't have the money yet, so I don't know exactly what's going to happen with that, but hopefully we will. So we'll have a kind of ideal situation for testing it. But bingo, so important, right? If we don't know if these additional contacts make a difference, then nobody's going to pay for it.
Right. Okay.
And the first step is to show that it does make a difference, and for whom it makes a difference. It may not make a difference for people who come into the ED who already have established relationships with clinicians, right? I mean, they may not need this additional therapeutic contact. They're going to go back to their clinicians, hopefully. Particularly if the clinicians have been helpful. But it may be very, very important for people who have real barriers to accessing care. So it's a first step. And yes, they're realistic problems, but no one's going to pay for it if we can't show it makes a difference.
All right, but the bottom line is, because I know PCORIs are practical and sort of real world interventions. The point is your funding will make sure that there's somebody home when you provide that access to care. It isn't like, oh, well, we're going to refer you to, middle heaven knows where mental health clinic, and they'll see you in 6 months whether you need it or not. You'll be able to provide what you really hope to. You're going to build a model that you hope you could duplicate if it turns out if it's effective. That's the bottom line.
It's yes. I'm really happy to hear your voice on the phone. I was worried you weren't going to answer, and I hope the text was good. here's someone that cares about you. And I have to say that we are using this approach in our NIMH funded Zero Suicide trial, where I was worried about it. We have follow-up contacts after in the continuation. We provide acute treatment for 6 months. And then in a continuation phase, we provide more caring contacts and additional support with their therapist calling. And we're finding that it, anecdotally, because I don't have the data yet, that it's making a real difference. And so even when we call, if things are fine, we're finding that those patients tend to call us and contact us if there's a problem. So it creates a link that makes it possible for people to get that care and to want that care. You know, there's somebody that cares out there. I'm not alone. I'm not disconnected. There's a caring health system that's going to provide a seatbelt for me and for my child.
Okay. Well, I've always liked your seatbelt analogy. Do you, well, obviously I know you pretty well and you do care and you can certainly transmit that in your voice. I'm wondering if in terms of hiring the people, they're going to be able to transmit that, that affect. When I had my shoulder surgery a few years ago, they provided a follow-up phone call, I think maybe to find out whether I died in the night or not. But anyway, I got the phone call and they said, well, you know, I'm supposed to call up and find out how you're doing. How are you doing? I'm living. Well, what's wrong? Oh, my shoulder hurts and I have a fever. Well, call your doctor. How about, and every question that they asked me and I was feeling miserable, I said, right, I'm a day post-op. I'm feeling miserable. We'll call your doctor. We'll call your, it was like, well, why did you bother to call me up if all you're going to tell me to do is call my doctor? So I think it's important for you to have a message in there, not just call your doctor when somebody is, when you do that follow-up piece.
Absolutely. And I'll just say for the medical profession that I was very sick about a year ago, and my doctor had a nurse navigator program basically, and they introduced me to the nurse when in person when I was there. And well, although then she shifted, and that was a lifeline for me when I was sick. You know, I knew that if I really felt bad, I could contact the nurse navigator, and the nurse navigator called me every so often, and I was glad to hear her voice. And I think you have posed the challenge. You know, if you call someone and they're feeling so sick they can barely pick up the phone, you picked the wrong time probably. You'd be better off calling their partner and finding out how they're doing and seeing if they need anything or anything that would help them to feel better. And our approach will do both. Although I must say that we're working both with adolescents and young adults, and some young adults may be living on their own, so it may be more challenging.
Maybe more challenging. Yeah, that's right. So your study was 15 to 24. And that's because that's the age group so you're not doing this with younger kids, I gather.
PCORI wanted this with age 15 to 24 for adolescents and young adults. So we did that. I would love to include some younger kids, but yeah. You know, as I said, I don't have the award yet.
I was going to say, we go where the money is. All right. Well, listen, it was fun listening to this discussion. And I hope that the people who are tuning in also learned some things that they can do in their practice, because I don't see why we have to wait until 5 years from now or however long it's going to be for you to come up with results. I mean, some of this just seems like decent common sense caring, and it should be implementable just even before you've got the data in. It can't hurt. I guess that's the question is, does it help enough to pay for, right?
Yeah. And thank you so very much for having me, and for any people who have been listening to this. Thank you for listening. And I should say that we have been, for the past 5 years, really disseminating our emergency intervention, the acute intervention with follow-up calls. And many of you probably who are listening maybe have implemented this in your emergency rooms. And a lot of people have reported that it's both doable and helpful.
I'm
so
not.
We can make a difference. We can be seatbelts. Let's hope we can do it.
Do it. I'm sure you can. If anybody can do it, you can.
Aww.
Well, okay. So thank you all very much today for listening. And I look forward to talking with you all for my next Screenside chats. And thanks again, Dr. Asarnow, for joining us. Bye-bye. Thank you all very much for tuning in. This is Gay Carlson for AACAP's Screenside Chats.
AACAP provides Screenside Chats as a member in public service, but it is neither a legal interpretation nor a statement of AACAP policy. Reference to any specific product or entity does not constitute an endorsement or recommendation by AACAP. The views expressed by guests are their own, and their participation in Screenside Chats does not imply an endorsement of them or any entity they represent. Views and opinions expressed by guests are their own and do not necessarily reflect the views of AACAP or any of its officials.